Hello, my name is Brooke Norman, and I'm excited to present my project on the use of caregiver training to improve stress and satisfaction acceptability in families of children with complex feeding challenges. I completed my capstone experience and project through the Ohio State University Division of Occupational Therapy and Nationwide Children's Hospital Homecare. I completed a systematic review on the PICO question for families of children with complex feeding challenges. Is caregiver training more effective than usual care in improving caregiver stress and satisfaction acceptability? This topic is very important because 25% of children have feeding challenges. And pediatric feeding is a complex co-occupation between a child and a caregiver. Caregivers of children with these challenges often report increased levels of stress and child-caregiver interaction difficulties. And thus, occupational therapists and speech-language pathologists have the unique skill set to provide feeding intervention and train caregivers to implement feeding strategies. Overall, my review found 6 articles that met the inclusion criteria. All studies included children with a mean age of 4 years with complex feeding challenges. Protocols varied across articles. However, intervention occurred over an average of 5 days per week across an average of 7 weeks. Caregiver outcomes of stress and satisfaction acceptability were evaluated via the Parenting Stress Index Short Form, or the PSI-SF, the Pediatric Inventory for Parents, or the PIP, and/or post-treatment caregiver questionnaires. Caregiver training was implemented across 3 phases over an average of 8 weeks described in the literature. Phase 1, about 2 weeks, included caregiver observation of therapist-led intervention. Phase 2, about 4 weeks, included caregiver implementation of treatment strategies with caregiver training via instructions, role play, and feedback from the therapist. And phase 3, about 2 weeks, included caregiver assuming the role of the primary feeder with therapist support as needed prior to discharge. Overall, I found that for families of children with complex feeding challenges, we do recommend the use of caregiver training to improve caregiver stress and satisfaction acceptability. However, this is a weak recommendation based on very low quality evidence. The goal of my project was to translate current evidence from the systematic review into Nationwide Children's Hospital Homecare. Although it was not implementable without significant revisions, and a gap does exist in the knowledge of the use of caregiver training with this population, specifically in the home care setting. So, an implementation analysis was completed to examine the acceptability, the appropriateness, and feasibility of this intervention to understand the barriers and facilitators to implementing the algorithm at Nationwide Children's Hospital Homecare. Some barriers of the current evidence included the child population age range from 0 to 19 years of age, the need for 100% of caregiver participation during each intervention session, solely behavior-based intervention primarily led by a psychologist, 8 weeks of caregiver training through three phases, specifically phase 2 of caregiver training being only 4 weeks in duration, the protocol and frequency of intervention of being an average of 5 days per week for only 7 weeks, and the outcome measures being administered at the start of care and discharge only, along with the cost of the PSI-SF to measure caregiver stress without knowing what would be best for the families at Nationwide Children's Hospital Homecare. And you can see the chart on this slide for further details on the barriers and supports of Nationwide Children's Hospital Homecare. After completing the analysis, I recommended strategies to support future implementation. The NCH Homecare Caregiver Stress Index and the NCH Homecare Caregiver Satisfaction Acceptability Questionnaire were created. I also recommended to increase communication with caregivers, problem solve challenges to active participation, and set a % of time for caregiver participation that's reasonable and feasible for families. I also recommend using the teach back technique to implement caregiver training, which is already being used at this setting. I recommend to increase communication between Nationwide Children's Hospital Homecare staff, especially during recertification and resumption of care processes and weight checks. And I recommend the continued use of the Nationwide Children's Hospital Homecare feeding meetings, and additionally to host quarterly feeding meetings with home care therapists, nurses, dietitians, and additional staff as appropriate. Revisions were made to the current evidence algorithm, and thus I created this NCH Homecare evidence-informed caregiver training algorithm to support the use of this intervention with the population of families seen in this particular setting. And you can see that I go through and I include the program, the eligibility criteria, the initial assessments, child intervention, caregiver training, and what should be happening during each phase and how long each phase should last, and additional assessments. Throughout my capstone experience, I also completed additional experiences and projects. I acquired knowledge, skills, and clinical experience in pediatric feeding interventions with a variety of diagnoses. I observed additional feeding interventions at 4 nationwide children's hospital home care, outpatient close to home centers, and the comprehensive pediatric feeding and swallowing program. I identified feeding resource needs, obtained and created handouts for families and clinicians, and shared resources using SharePoint for clinician access. On the left, you can see that I designed a caregiver stress index and a caregiver satisfaction acceptability questionnaire, including questions directly related to feeding for the population of families seen in this setting. I developed a clinician's guide to pediatric feeding disorders to help any therapist identify and support families of children that may have these difficulties. And I also developed and delivered a presentation for staff education on caregiver training and supplemental resources. I created an Excel spreadsheet to identify gaps in feeding resources at the home care setting and to understand modifications for best practice. I also attended OOTA Central District Board meetings and OOTA advocacy calls. I assisted in the planning process for the Ohio State University Occupational Therapy Capstone presentations co-hosted by OOTA. I completed the Supporting Oral Feeding in Fragile Infants, or SOFI, continuing education, and I completed assorted readings on pediatric feeding, such as the Infant and Child Feeding and Swallowing, Occupational Therapy, Assessment and Intervention textbook. Thank you so much for listening. Additional questions can be made to the author via email at brooke.norman@osumc.edu. Thank you.